Well, I have 5 o'clock, so we'll go ahead and get started. This session is going to be about engaging off-service rotators from other services in the emergency department and how we can add value to their clinical experiences with us. So I'm Krystin Miller, and I'm honored to co-present today with Lauren Willoughby, and we're coming to you from Ohio State. So just to get us started, a question for everybody. Who has or works with off-service rotators in your emergency department? Yeah, I think that's not unique to us. It's not unique to academic medical centers. But I think that the experience that we provide our off-service rotators is probably variable amongst our programs. And so just kind of looking at our rotators and at our shop, we do have a pretty large proportion of our house staff who rotate with us in the emergency department. We have about 95 rotators a year that provide us about 15,000 clinical hours of time in the emergency department. Our rotators come to us from internal medicine, both in their PGY1, PGY2, and their prelim years, but we also welcome interns from ENT, orthopedics, and then our PEM fellows from Nationwide Children's across town from us. How many of you have dedicated programs or didactics or curriculum for your rotators at your institution? Great. I think when we look at the literature, and we'll talk about that in kind of the next slide, the curriculum that exists for rotators is probably pretty variable as well amongst programs. And so for us, at least for the last 6 years that I've been at Ohio State, the program was you showed up on your first day of your rotation, and the senior resident or the attending who was working on your side that day would give you like a brief crash course about this is how the EMR works, and this is how we staff patients, and this is the flow of our department. Our rotators would work their 15 or 20 shifts with us in the emergency department and then would move on to their next rotation. Maybe they would get some dedicated feedback at the end of their shift. Maybe they would get some on-shift teaching, but there was nothing that was standardized amongst our rotators, amongst those 100 rotators that were with us every year. And so we did not really have a formal curriculum. So I think those were some of the questions that I started to ask myself as a senior resident, as a chief resident, as a med ed fellow, about how could we improve that rotator experience? How can we improve the engagement of the rotators when they're with us working in the department? And how can we really add value to their clinical experience while they were with us in the emergency department? And I think those questions gained even more weight and even more importance over the course of the last year as our internal medicine, as you may or may not be aware, revised their common program requirements. And so for a while in those discussions, emergency medicine was on the chopping block as no longer even being a required rotation for the internal medicine residents. For us, that represented over 75% of our rotators, so a very large chunk of our rotators were from those internal medicine programs. In the revised common program requirements that will take effect on July 1st of 22, EM is still a required rotation, but no longer is there a specified length. So it is variable amongst programs and amongst institutions, whether they're going to require their internal medicine residents to rotate with us for 2 shifts, 2 weeks, 4 weeks, and what that might look like. So we really felt like it was important to make sure that this was a valuable rotation that held value, that the IM program directors and the other off-service rotating program directors felt that this was a valuable rotation to keep as part of their program. And so as we were thinking about how can we implement a new program, we went to the literature. I'll be honest, the literature about off-service rotating residents and curriculum is pretty sparse. Some of the most recent data that we could find published was from as recent as 2010. And so there was a survey of program directors, all of the ACGME accredited EM programs that was done by Branzetti and al. They overwhelmingly, like greater than 95%, all had rotators at their institutions. But when it came to didactics, only 5% had dedicated didactics for specified rotating residents. 64% sent their rotators to their EM, either medical student or their resident didactics each week, and 31% had no didactics at all, which is kind of the bucket that we fell in at Ohio State. When they also surveyed those program directors, they asked about what do you think are some of the most important subjects that should be covered if you were to implement a didactics, and resuscitation, trauma, and toxicology were things that came to the top of that list. Similarly, in 2010, Kessler et al. Published a needs assessment. And this was a survey to 171 internal medicine residents at 2 different programs, asking about what did IM residents feel that they were inadequately prepared to take care of in their emergency medicine rotations. And some of those topics included airway management, ophthalmology, as well as environmental emergencies and orthopedics. So we kind of took that framework of those needs assessments, the fact that we didn't have anything, that we felt that it was important to start thinking about ways we could add value for our rotating residents in the emergency department, and applied Kern's model to kind of develop a curriculum. So it was like January of last year that we started putting our heads together to build this curriculum. And really our problem statement was pretty simple. We didn't have a dedicated program or any formal curriculum for our off-service rotators, and how could we implement that? So I'm going to turn it over to Lauren, who's really going to walk us through the next 5 steps of Kern's model and what did that curriculum development process look like for us.
All right, so after we had identified the problem, the next step we went on to was actually sending out our needs assessment. So the needs assessment that we sent out, we sent it to off-service rotators who had been in the emergency department within the past 2 years, as well as the program directors of those off-service rotations to get an idea of what they were hoping to achieve and what they wanted to get from their time in the emergency department. So our needs assessment used the Likert scale, so it was rating these components from 1 being poor to 5 being excellent. These were the 4 things that scored the lowest in the needs assessment. So orientation to the emergency department, their communication with program coordinators, their procedural training and procedural education, and then the feedback that they were receiving from their shifts. So from the needs assessment, our next step using Kern's curriculum development was to come up with our goals and objectives. So really our overall goal for our off-service rotator curriculum was to improve their engagement on service, also improve their knowledge acquisition, and then to just really improve their overall satisfaction and the enjoyment they got out of spending their time in the emergency department. So next, we went on to our educational strategy as well as implementation. So as far as the educational strategy, these were the 4 big things that we changed and made improvements on in our current off-service rotators. So really, we had a dedicated faculty member. So for us, that was Dr. Miller. She served as that point person. Which was really helpful for the off-service rotators because then they felt they had someone to contact if they had any issues or questions come up on their rotation. We also gave an orientation session. The emergency department is very different than what most of the off-service rotators were used to. So we went over department flow as well as charting and other things to help them be successful during their month with us. We also had end-of-shift evaluations, so these got sent out automatically from the evaluation system that we use. So at Ohio State, we use MedHub. So after each of their shifts, evaluation would be sent to the attending that they worked with, so that they were able to get real-time feedback. And then finally, the weekly didactics and procedural training was another thing we implemented. So our curriculum, it spanned 4 weeks. It was 2 hours a week. So we did Monday mornings from 8 a.m. till 10 a.m. All of the off-service rotators had that as protected time off so that they could attend the didactics. And then since we were asking them to do this additional requirement, we were able to give them a 1-shift reduction as well. So based off the needs assessment and then the literature review, we came up with this 4-week curriculum. So week 1, as I mentioned before, the first thing that we did was give an orientation to the emergency department. Again, focusing on flow, charting, and other things to help them out. And then the approach to the undifferentiated patient, since that's very unique to emergency medicine and maybe something that they had not had to do before. Week 2, we focused on airway management as well as undifferentiated chest pain. Week 3, we brought in simulation and introduced the patient in shock, and as well as critical care ultrasounds. And then finally in week 4, we focused on trauma, orthopedic injuries, and intoxications and toxidromes, because this is very unique to emergency medicine and something that they may not have had exposure to before.
And then finally, just like kind of any curriculum, evaluation and feedback was kind of the last step in this process. And so at the end of the rotation, we sent evaluations of the rotation to each of the off-service rotators and asked them to give us some feedback. And so one of the first questions is we asked them to rate the quality of some of the different components of the rotation. And these mimicked some of the same things that we were asking about in that initial needs assessment. And so I highlighted these first 6 because these were some of those areas that we had identified as our weakest points from our needs assessment, and where we were really able to show some improvement with implementing a formal curriculum. So the numbers in parentheses are their Likert scales, their means on a Likert scale of 1 to 5, 1 being poor, 5 being excellent. And if you remember back to that first slide about the needs assessment, we were kind of in that mid-2 to 3 range for most of these areas, and we were able to improve those to the kind of mid-4s range. This data just represents the first 6 months of our curriculum, so through January of this year. We had a 56% response rate. 28 of the 50 rotators that rotated with us through those first 6 months of the curriculum responded to the survey. And so I think we saw some improvements in kind of how they viewed the quality of their orientation, their communication with the chiefs and program director, the rotator director, their procedures education, as well as their feedback. We also asked them kind of specifically about the value and the quality of each of those weekly didactic sessions that we were doing as we kind of evaluated each of those components individually. In terms of importance, our rotators viewed the shock simulation and the undifferentiated chest pain lecture as the most important. And in terms of quality, the ultrasound workshop and the airway management workshop as the highest quality components. And those kind of numbers that are listed are, again, their Likert scale from 1 to 5 and kind of the range of how they rated those components of the curriculum. I think like anything, there's always room for improvement. And so one of the things that you maybe didn't see on that last list of like good things was feedback. And so that was still an area that's an opportunity for improvement for us that's still kind of in that mid-3 kind of satisfactory range for us. And as we think about why that is and why that might be happening, I think there's a couple of things that come to mind. First, the end-of-shift evaluations do automatically get sent in MedHub by our program coordinators to the attending that they're working with, but it is dependent on that attending to fill out the evaluation, so response rate from the attendings are variable. The other kind of component is those evaluation results get released to their programs, and it's up to their home programs, so internal medicine or orthopedics, how they release those. So some of those programs don't release until the end of the year. Some release in real time as they're completed. And so that is an area of opportunity for us to work with our collaborating off-service program directors about how we release that feedback so that it can be meaningful in-time feedback that we can get to them. We asked for some kind of free text comments about things that we can improve and do better on at the end of the survey as well. And a comprehensive end of rotation evaluation was something that came up. So how do we do overall on the rotation when it came to simulation, when it came to didactics, when it came to procedures, when it came to our on-shift performance? And that's something that we had not implemented in the last year and have to think about how we could potentially do that moving forward. And then I think one of the other things that came up in the free text comments was scheduling. When you take off-service rotators who are used to a clinic or a inpatient service schedule, our emergency medicine schedule is very different and unique. And so figuring out how we can make them comfortable with the shift changes, the night shifts, the morning shifts, the afternoon shifts, and accommodate all of their needs are another area that we can kind of think about in terms of opportunities for next year. So in summary, I think a couple things. We've learned a lot of lessons about implementing a rotator curriculum. I think we all understand that we work with rotators, and they are certainly a large part of our workforce in our emergency department, and we really depend on them to help us care for patients. But thinking about how can we add value back to their clinical experience, giving them value from what they're learning from their patients, but also giving them some knowledge that would translate to other areas of the hospital and patients that they're caring for. Because I don't think any of us would argue that it's important for an internist, a cardiologist, an orthopedic surgeon to understand how their patients walk through the front door of the hospital, get triaged in an emergency department, and get admitted to their service. And so we certainly see that value, but we need to be able to translate that value back to them as learners. And so, I think if I were summarizing some of the things that we learned and the lessons learned, and I wanted to say, here's the 5 things that you could do to maybe add value to your clinical experience for your rotators, I think this is maybe where the money is. Orientation first and foremost. I think getting them comfortable and getting them oriented is something that's really easy and a simple intervention to do, but can really make a difference for our off-service rotators. I think having that dedicated faculty contact, although I only got a couple of text messages or a couple of phone calls or direct emails over the course of the year, having that person to be a contact, I think, is really important. They're used to being on a service where they maybe work with the same attending for a week or 2 weeks at a time, and they might come to our emergency department and work with 15 different attendings and 15 different shifts. So having that continuity of a familiar face that they're seeing multiple times throughout the rotation, I think, was really helpful to build rapport and build comfort and build educational safety for our rotating residents. I do think I was skeptical / didn't know how much they would view the didactics as helpful or important, but I think that they really did view those in our end of rotation evaluations as helpful and important. And we tried to make them things that would relate to whatever they were doing. So when we were presenting cases in the airway workshop, it was, hey, you're called overnight to an ERT on a patient that is, on the floor on a service that you only know a little short one-liner about. So we tried to make it things that were EM applicable, but would also apply to their life outside of emergency medicine. That really utilized our skill set and captured our skill set as emergency physicians and imparted that to them in ways that they could use it in their clinical environment. We talked about feedback. I think that all of our learners want feedback, and there's always room for improving how we can give feedback. And then lastly, this is something that we didn't necessarily seek out to study, to intervene upon, or to have a direct intervention for, but it was something that came up as a continual theme in all of the comments from our end of rotation evaluations, and that was the team dynamics in the emergency department. Overwhelmingly, there were comments of, I really loved the team in the ED, the attending was really welcoming, the senior residents were really welcoming, we felt welcomed in the emergency department, and so I think just that speaks to the importance of, as we're welcoming these residents from off-service rotators, to really optimize their experience. It's really about making them feel welcome and part of the team. So with that, that's kind of what we've done and what we've learned, and some lessons along the way, and we're happy to answer any questions. Yeah, so we did have a free response, and we had a couple of things what did you view as the strengths and what did you view as potential areas for improvement? Scheduling was one of them. They wanted no night shifts. They wanted nights off before didactics, a lot of kind of logistical scheduling things that came up. And so I think part of that is education on our side about this is how emergency department schedules work and function, and that's, not realistic, so kind of managing some of those expectations. So I think that was where kind of some of the scheduling came in. Feedback was the other thing. So they felt like they weren't getting real good feedback on shift. And so that's something for us to kind of troubleshoot on our processes side as well. Yeah.
Did you see their patient volume increase as they went through this? They started seeing more patients, a little bit more engaged, or they still have seeing 4 patients a shift?
Yeah, so it's not something that we studied, and we didn't really have any data to kind of pre and post of their volumes. I think anecdotally, I felt like the rotators were more engaged. Maybe it was because they were working with me and they knew me and they had seen me on my shifts. But I did feel like I have felt like our rotators have been a little bit more engaged and feeling like they're part of a team. And I think it's as simple as just welcoming them and having an orientation and doing some of the basic things to welcome them. Yeah.
When did you incorporate conversations
Yeah, so we implemented a couple or introduced a couple of different decision rules, and it was scattered throughout. So in the undifferentiated chest pain lecture, we talked about kind of Wells and Perk and Hurt score. That lecture was kind of set up case-based to kind of go through the 5 life-threatening causes of chest pain, and we kind of worked through each of those, kind of just thinking about undifferentiated chest pain and emergencies to rule out, and so we incorporated those in that conversation. In the trauma and kind of musculoskeletal orthopedics lecture, we talked about Canadian C-spine and head CT nexus, some of those. We didn't touch on any of like the Ottawa ankle rules or anything, but yeah. So we incorporated a couple of them when we could, but scattered out through those lectures. Yeah. Yeah.
What do you think the hardest solutions you've had were to implement? What barriers you had to that?
Yeah, I think time. This is a commitment of, we had to run 2 different orientation sessions because we have some of our senior residents start on a Wednesday and our junior residents start on a Monday. So, 2 orientation sessions, 3 other days of didactics. So when you add that all up, that's just 10 hours of educational time. But it was a commitment that we made and have been able to carry forward.
Just curious if other people have noticed when it comes to that over time, these off-service rotators, either you see fewer of them, you get rid of the rotation, or you cut it down. I'm just wondering if other places have noticed that. We published a paper over 20 years ago about this, and we surveyed all the program directors, and we did something back then. And I can tell you since then, we probably had some other services pull out, everybody from surgery, OB, oral surgery. I'm just wondering if other people have noticed that as well. Definitely, this really helps. So congratulations.
Any other questions? Great. Well, thank you all.